Hello, and welcome to the ACR Journals on Air podcast. I'm your host, Vicky Shamagam. Assessing disease activity in large vessel vasculitis can be a challenge. And as imaging techniques evolve, clinicians must evaluate how to harness new imaging modalities in clinical care. The manuscript we will discuss today is Association of 18F-fluorodeoxyglucose positron emission tomography activity with angiographic progression of disease in large vessel vasculitis. It was recently published in Arthritis and Rheumatology, and a link to the manuscript and disclosures are in our show notes from today. I'm excited to be joined by the manuscript's first author, Dr. Caitlin Quinn. Dr. Quinn received her medical degree from the New York Medical College. She then completed internal medicine residency and rheumatology fellowship training at my alma mater, Georgetown University Hospital. Caitlin was on faculty at Georgetown for several years before then completing a 2-year Vasculitis Clinical Research Consortium Vasculitis Foundation fellowship within the NIAMS Vasculitis Translational Research Program. She focused on imaging large vessel vasculitis and developing outcome measures in vasculitis. And she is now a staff clinician in the Vasculitis Translational Research Program at NIAMS. Welcome to the show, Caitlin.
Thank you for having me here today.
And Caitlin, just by way of further disclosure to our listeners, although we both trained at Georgetown, we actually didn't really overlap. I think you were a resident there when I was just finishing up my faculty position, and then we didn't overlap at all through fellowship or on faculty. So I wondered if you could start us off with a little bit of background to this particular study. PET scanning, we know, identifies vascular inflammation in large vessel vasculitis, but there's not a whole lot of data that looks at longitudinal imaging and using PET scanning over time to follow patients and their outcomes. Can you explain to us that background and why it was necessary to do this study?
Yes, we're seeing that different types of vascular imaging, including PET scans and also including non-invasive angiography with MRA or CTA and ultrasound, are all becoming increasingly used in large vessel vasculitis. And now both the ACR and EULAR in their recent recommendations support the use of PET scans to make a diagnosis of large vessel vasculitis. But as you point out, we have less data about whether PET scans are useful to follow and monitor patients over time. We've seen in cross-sectional studies that many patients who have large vessel vasculitis will have ongoing PET activity later in the disease, in some cases when they're feeling well and in clinical remission, and nobody really knows the meaning of ongoing abnormal PET activity late in the disease and whether it predicts future events and what to do about persistent PET activity, if anything. So the purpose of our study was to really look at that longitudinal relationship between PET activity and future angiographic change on MRA or CTA in patients with a diagnosis of large vessel vasculitis, and to see, did PET activity predict which patients were going to develop damage to their arteries down the line or not? And should we be worried if a patient has ongoing PET activity?
Yeah, and all of the patients in this study were followed at the NIH. So all scans were performed at the NIH Clinical Center. And for those of our listeners who don't know, clinical care at the NIH is quite unique in that every patient in that hospital is on a clinical research protocol. Who were the patients you recruited for this study? At what point in disease were they enrolled? And who was driving treatment decisions for these patients?
Yeah, so exactly like you said, every patient who comes through the NIH Clinical Center is enrolled onto a research protocol in order to be seen. So patients can't just walk in or call to make an appointment. There's a screening process. Patients are invited to come to the NIH and be evaluated if they fit under a specific research protocol. But in addition to coming to the NIH for doctors to make recommendations about their care, patients are also contributing to the advancement of research by coming here and enrolling onto a research study or protocol. So in our study, our vasculitis translational program within NIAMS, we have a natural history study where we're able to see and evaluate any patient who has a diagnosis of vasculitis. So we see patients with all different forms of vasculitis, but we've really been particularly interested from a research standpoint in seeing patients with large vessel vasculitis. So the patients recruited for the study, we had a mix of patients we see who are local to the area. The NIH is in Bethesda, Maryland, for those who don't know, and then patients who travel from all over the country to come and participate in research. And patients really could be at any point in their disease course, from newly diagnosed to having had the disease for several years or longer.
So some patients were enrolled even at the point of remission. They were in remission when they enrolled?
Yeah, so patients were on different treatments and some were late in the disease course. We did see that many of our patients still had ongoing clinical symptoms and clinically active disease at the time of their baseline evaluation when we were first seeing them, but some patients were also late in the disease course and doing well and in remission.
And tell us a little bit more about the breakdown of the study cohort. I think you included patients with both giant cell arteritis and Takayasu's arteritis. How did you stratify according to treatment regimens? Could you explain that to our listeners?
Yeah, so we had a total of 70 patients with large vessel vasculitis. About half of them had a diagnosis of Takayasu's arteritis, and the other half a diagnosis of giant cell arteritis. Patients were on various treatments at the discretion of their treating physician, who was primarily managing their care when they were enrolled into our study. So some patients were on steroids, some were on DMARD therapy, and some on no treatment at all.
And then how did you design the imaging protocol? And can you tell us a bit more about what other imaging was included? So how did you define disease activity and angiographic change over time?
So every patient had a baseline whole body PET scan, and the protocol for this was designed with our nuclear medicine department, and Mark Ullman, who's the second author on this manuscript, played a big role in that. But really the protocol is similar to a PET scan obtained at any institution, with one major difference, which is at most institutions, a PET scan is obtained an hour after the radiotracer or FDG is injected. And this is because this is what's typically done in oncology when PET scans are being used to evaluate for tumors. So we end up waiting an extra hour and obtain the scan 2 hours after the FDG is injected. And that extra time gives more time for the radiotracer to uptake into the wall of the artery and simultaneously clear from blood pools. So really, it optimizes visualization of the large arteries.
Interesting. I don't know that everyone knew that there was a different timing protocol for vasculitis.
Yeah, that's the main difference between the scans that we're doing and scans done at other institutions. But really, nothing needs to be done differently other than the patients in the waiting room for an additional hour waiting for the radiotracer uptake time.
Perfect. Okay. And then what about the other imaging and disease, sort of assessment of disease activity?
Yeah, so the second part of the imaging is the angiography. So either MRA in most cases or CTA in some cases where patients couldn't get MRIs done. So patients would have an angiogram of the aorta and the primary branches at the same time as the baseline PET scan, and then a follow-up study at least 6 months later for comparison purposes. Some of our patients were on the study for longer periods of time, depending when they were enrolled. So patients who had multiple follow-ups at 6-month intervals, the baseline and most recent images were compared to kind of look for change over the longest time interval that we had. And what we were looking for was the presence of vascular damage. So this was defined in our study as luminal changes. So if a patient had stenosis or narrowing of the artery, occlusion, or aneurysm affecting the artery, we considered them to have vascular damage. And we looked over follow-up, did they develop any new damage? And in cases where they had existing damage, did this improve, worsen, or not change?
And so that MRA or angiogram was the sort of the gold standard assessment of disease activity or remission or progression?
Exactly, to see if the baseline PET activity was associated with change on the angiogram over time.
Got it. And on the PET scan, you analyzed this qualitative uptake and then the semi-quantitative uptake measures. Can you explain to our listeners what that involved and why both types of analysis are important?
Yeah, so the qualitative assessment is easier and much more feasible and faster to do in practice. So our nuclear medicine physician would visually assess the degree of PET activity in each artery compared to a background tissue. And different background tissues can be used. We use the liver as the background tissue in this study, but essentially PET activity is graded in each artery on a scale of 0 to 3, with 0 being no uptake and 3 being greater than the liver uptake. And any 3s are considered to have active vasculitis in that territory. So this is more of just a visual assessment. And then the semi-quantitative uptake measures are more precise, but technically a lot more difficult and time-consuming. And this is looking at standardized uptake values, or SUVs, and measuring the exact amount of radiotracer uptake in each territory.
And so in clinical practice, are both typically done, or can you provide any advice to our listeners who are ordering these tests on our patients?
Both can be done in clinical practice. The qualitative assessment is what's typically done by the nuclear medicine physician. And I think more in research settings, the semi-quantitative uptake measures can be used because it just is more precise, but takes a lot more technical skill and is time consuming.
Yeah. And then you also did another analysis that I'm hoping you can explain for our listeners, which was this territory matched analysis. What was that, and how did that allow you to use the patients to serve as their own internal controls?
Yeah, the idea for this came from Tahina Niyogi and Mike LaValle at Boston University, who are co-authors on this paper, and they had used a similar model in their prior knee osteoarthritis studies. So they were looking at patients in their studies who had discordant knee pain with pain in one knee but not the other, and the association of pain with radiographic features of osteoarthritis. And this within-person match design eliminates any person-level confounding variables that you come across. So we wanted to adapt this model because we saw from our data that most of the cases where angiographic change was occurring was happening in discordant paired arteries. So, for example, a patient would develop damage on MRA in the left carotid artery over follow-up, but no changes on the right carotid artery. And so our goal was to look at baseline PET activity in the artery that changed over time versus the paired contralateral artery that didn't change over time within the same patient. But because we were doing the study in the context of an observational cohort, as we talked about, patients had differences in disease duration and different lengths of follow-up and were on different treatments. So this analysis really eliminated some of those person-level confounding variables that we were struggling with.
Yeah, it makes a lot of sense. And I'm sure leaning on that expertise was well worthwhile. So tell us what you found. Did the FDG PET at baseline help you identify those patients that were likely to progress? And can you walk us through the flow graphic in figure 1, explaining how you analyze the vascular activity in the two groups of patients, those with giant cell arteritis and those with Takayasu?
Yeah, so figure 1 in the paper is looking at change in arterial damage from baseline to follow-up. So starting on the left in the figure, we had 70 patients with large vessel vasculitis included. 38 of them had Takayasu's arteritis and the other 32 giant cell arteritis. And we looked at 17 different arterial territories in each patient. So you can see overall the total number of territories assessed across the 70 patients. And on the baseline imaging, you see the number of territories with and without PET activity, and then also the number of territories with baseline existing arterial damage on MRA or CTA. And then we were looking over the median interval of 1.6 years to see what happened over time and show the number of territories that developed change on the follow-up imaging study. So overall, the 3 big take-home messages from this figure are that 1, we saw there was little angiographic change overall occurring, and a lack of PET activity was strongly associated with stable angiographic disease. So territories with no PET activity were unlikely to change on follow-up. And then 2, the number of territories with baseline PET activity also didn't develop angiographic change. But 3, in cases when angiographic change did occur, it almost always was preceded by the presence of PET activity. And so in that within person territory design that we just discussed, an arterial territory that had baseline PET activity had a 20 times increased odds for angiographic progression over follow-up compared to the matched arterial territory with no PET activity.
Fabulous. And thank you so much for walking us through that figure. I have to confess, I actually love seeing how scientists put their data into graphics because I think it tells you quite a lot about the scientist, a little bit like pets and their owners. And when I saw that graphic in yours, it made me laugh because I couldn't help but thinking it looks a little bit like a vascular bed. And you use it incredibly effectively as a conduit to show how the patients flowed through the study. I'm wondering, was that in your mind as you designed the graphic?
It does look like a vascular bed and is on theme, I guess, with the rest of the manuscript. However, it wasn't by design, and I have to give credit for this figure to Hugh Alessi, who's one of my co-authors on this manuscript. And Hugh is now a medical student, but spent a couple of years working with our group as part of a post-bac intramural research training program. So as we were thinking through how do we best show these results effectively, Hugh suggested the use of a Sankey diagram, which is what figure 1 is, kind of used to depict flow from one set of values to the other. And I think figures end up being one of the key aspects of any paper and what people end up focusing on. And diagrams like this can give you kind of a quick visual summary rather than having to sit through and analyze all these numbers in a table.
Well, I love it. And I'm so glad you told us who came up with the idea. And I think it's great that it's somebody who is now a medical student. So your results are kind of reassuring that this age-old worry of silent progression doesn't really play out in your cohort. Can you tell us what factors do predict progression and what factors predict either new or worsening vascular damage?
Yeah, so to your first point in our study, we saw that no patients had silent angiographic progression or worsening damage in the absence of corresponding symptoms. And all of the patients we saw who did have worsening damage also had symptoms that corresponded. I think this finding should be interpreted with some caution because the patients we were seeing were getting standardized clinical assessments in a research setting. So this could have led to detection of symptoms that may have otherwise been missed and underreported. So I think it's hard to say from this study definitively that silent angiographic progression doesn't occur, but maybe it's a less frequent phenomenon than previously thought. But what we did find predicted progression in our analysis was that patients with Takayasu arteritis compared to giant cell arteritis were more likely to develop new or worsening damage, and then so were patients who had active clinical disease.
Yeah. And you also looked at this interplay of the vascular activity on the PET imaging with the presence of vascular wall edema and thickening on the angiographic imaging. Can you dissect that for us?
Yeah, so we looked at wall morphology changes on the baseline angiogram, the presence of wall thickening or edema. And what we found is that patients who had baseline PET activity, but also had baseline wall thickening and edema on angiography were the patients at greatest risk to have angiographic change over time. So I think this really supports the value of multimodal imaging and incorporating different forms of imaging when you're assessing these types of patients.
Yeah, and can we talk about the flip side of that equation? So you did actually have some patients who showed improvement in imaging, so sort of this quote unquote healing of lesions. Were you able to identify any predictors of patients who do well or but go into remission but even improve?
We did. So we saw patients who had existing damage, either worsening could occur over time, but improvement also happened in some cases. And this is something that's been reported in other studies as well, although I think we often think of damage as being irreversible. Overall, we had too few angiographic events to be able to compare and evaluate worsening and improvement separately. But I think whether a patient ends up improving or worsening over time may tie into where they are in the course of their disease, early versus late, and what treatment they're receiving over the follow-up periods.
Yeah, and I wondered, I know you touched a minute ago on some of the limitations of this study. Could you expand a little more about the nature of these research protocols? I know probably the patients being seen in your clinic were relatively aggressively treated and pretty compliant, certainly with follow-up when they came to the NIH for research imaging. How do you think this will play out in real-world clinical care?
Right. I think there's possible selection bias here, so that patients we're evaluating at NIH have to be willing to come and participate in research studies. We didn't have any geographic restrictions in place, and we see patients locally and from all over, but patients have to be able and willing to travel and want to come to participate. And then we did this study in the context of our observational cohort. So patients, as we've talked about, had different treatments, were followed for different time intervals depending when they were enrolled into the study. So the within-person matched design we spoke about earlier addressed some of those differences to help limit confounding between patients, but these variables were still challenges to deal with.
Yeah, and all the patients were outpatients, is that correct?
Exactly. Yes.
So nobody was sort of your typical active vasculitis inpatient management.
Exactly. Patients had to be well enough to come to outpatient visits and weren't admitted to the hospital.
So that brings me to the $1 million question. Do you recommend that clinicians use FDG PET scanning to monitor large vessel vasculitis in the clinical setting?
Yeah, it's a great question. And I think complex, and there's not one easy, straightforward answer on how to best approach PET scanning in the clinical setting. I think from our results, we're seeing that a negative PET scan is reassuring that there's unlikely to be angiographic change over time. In cases where someone has ongoing PET activity, I think there's some differences between Takayasu's arteritis and giant cell arteritis. So many patients in our study with giant cell arteritis had ongoing PET activity, and yet none of them developed new damage. Whereas in Takayasu's arteritis, we saw that association between PET activity and subsequent angiographic damage. So it may be that patients with Takayasu's arteritis benefit more from frequent imaging to monitor disease compared to GCA. And then there's other specific clinical scenarios where I think serial PET monitoring can be useful in the clinic. So if you're seeing a patient who has a symptom and it's hard to tease out whether it's from ongoing vascular inflammation or damage, a PET can be helpful to differentiate. And then finally, as I mentioned, I think the value of multimodal imaging can be really helpful, as we saw areas with PET activity and wall morphology changes on MRA were the ones at highest risk to progress.
Yeah, and I feel like your manuscript actually was so helpful, I think, for clinicians at the bedside looking after patients and trying to negotiate with insurance companies to cover this type of very intensive imaging and expensive imaging. I'm sure that many people will be thanking you for the work that you've done and hoping that you continue to work in this field. Continuing our kind of vascular puns, I was hoping we could move into a different territory now and talk a little bit about your journey as a clinician investigator. Can you share with our listeners how you got involved in vasculitis research and why, after so many years of training and finally reaching a faculty role, you took a left turn to complete this Vasculitis Clinical Research Consortium Vasculitis Foundation Fellowship?
Yeah, so I did my rheumatology fellowship at Georgetown. I know you spent time there too. And I saw a lot of patients with vasculitis during fellowship. I worked with Dr. Thomas Cups at Georgetown, and really I became interested in caring for patients with vasculitis. And I think as my interest grew and I graduated fellowship and was on faculty working to build up a vasculitis clinic, I heard about the opportunity to do a fellowship through the Vasculitis Clinical Research Consortium and Vasculitis Foundation. And this is a mentor training program for physicians who have a strong interest in vasculitis and want to pursue more specialized training and get involved with research. So a main aspect of the fellowship is to identify a mentor to work with who specializes in vasculitis and has expertise. And so I reached out to Peter Grayson, who's the head of the Vasculitis Translational Research Program within NIAMS, about potentially working with him. And he was willing to serve as a mentor, and I applied for and was awarded the fellowship. And during my vasculitis fellowship is really when I got more involved with research. I worked on several research projects and really found that I enjoyed the research aspect in addition to clinical medicine. I think particularly as there's so many unmet research needs in vasculitis.
Yeah. And during that time, I think you also completed the Duke Masters of Health Sciences in Clinical Research. Can you tell us about that program and how long was it? How involved was it? Did you do it remotely or did you travel down to Duke?
I did, yeah. So this is a program, a collaboration between Duke University and the NIH that's been in place for a number of years. So it's designed for physicians at both the NIH and Duke wanting to further their skills and clinical research. So in non-COVID times, there would be a lecture room and lectures would be streamed into the room. I ended up doing it remotely on Zoom because of the pandemic, but it was a 2-year program and it involved coursework in research design, clinical trials, statistical analysis, as well as a thesis and research project. And so I completed the program last year, and actually the work covered in this paper was the focus of my master's thesis.
Oh, brilliant. I didn't realize that.
Yeah.
That's great. And actually, I'm hoping then that trainees will look at it with a different eye. I feel like that is a fabulous program and a super opportunity. Is it now totally online? So could people enroll from all over the country?
Yeah, I think I'm not sure about this upcoming year, but the past couple of years has been completely online. I'm not sure if it's only offered to those working at Duke and the NIH, but I think, yeah, potentially something that could be done by others.
Great. And so tell us a little bit about what it's like to work at the NIH. It is a really unique environment. Tell us about it.
It is. I really enjoy working at the NIH. As you said, it's very unique and really unlike any other institution that I've been at. And I'm really appreciative of the opportunity to work here. Again, we see patients from all over, sometimes internationally, who have these really complex diseases, and they're coming for clinical evaluations, but also contributing to research to really help advance the understanding of their conditions and ultimately help other patients down the line with the same condition. So that aspect is just amazing.
And how do clinicians outside of the NIH refer patients? So if someone has a vasculitis patient who's interested in being seen by your team, how does that work?
Typically reaching out to myself or Peter Grayson or our research nurse, and then we usually start the process of requesting records and seeing if the patient would be a good fit to see under our protocol. But particularly patients with large vessel vasculitis we're really interested in seeing. And so anyone who has a patient who they think would benefit from an evaluation at the NIH can reach out to me.
Yeah, fabulous. And speaking kind of from the other side, as someone who has referred plenty of patients to the NIH, I can tell you it's always helpful to get consultative opinions from your team. And I'm always excited to see the research that you're able to do. So Caitlin, in your many, many roles at NIH, you are also Associate Director of the Rheumatology Fellowship at NIAMS. Can you tell us about the NIH training program for rheumatology fellows and what unique opportunities does training at the NIH bring for fellows?
Yeah, I think it's a really strong fellowship training environment. There's great clinical training and an opportunity to see a whole wide range of different diseases, including many rare conditions, both in the rheumatology clinic and also on the consult service. There's a lot of strong didactics and educational conferences, and also opportunities to collaborate with other institutions in our area. And then the opportunity to really hone in and develop research skills, working closely with a research mentor to develop and complete a research project during fellowship. So overall, a really great and unique place to do rheumatology fellowship training, I think.
Yeah, and to be clear, your hospital has a vast array of patients that it sees from A, all over the country and all over the world, and B, the full spectrum of disease. And so as the fellow on the consult service, you can be consulted for what seems to be a simple case of gout or a very unique rheumatologic complication of a rare genetic disease that you don't see very often. Is that right?
Right. So a wide range of different conditions, and often consults for gout or osteoarthritis are on the background of patients having these rare conditions. So I think an opportunity to see things that you otherwise may never see.
Yeah. And your fellows go on both to research careers and then also some to other universities as faculty and some into private practice settings. Is that right?
That's right. I think we've had a range of graduating fellows doing all different sorts of things. Some go into clinical practice, some go the clinician educator route or work at university settings, and then some stay more focused on careers as physician scientists.
Oh, well, Caitlin, thank you so much for joining us on the show and sharing your research, sharing your path as a physician scientist. And I can't wait to hear more from your group as your vasculitis research program continues to grow and blossom, hopefully not like a revascularizing bed of vasculitis, but as a growing tree. Thanks also today go to our advocacy groups, including the Vasculitis Foundation, that provide additional opportunities for scientists in our field to subspecialize and pursue novel research pathways. Their advocacy and innovation can be instrumental in moving our field forwards. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow @ACRheum on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.